Welcome to Section 4 in Musculoskeletal Anatomy. In this section, we will discuss the thoracic outlet, the rotator cuff, and the muscles involved around the shoulder. Let's get started. Let's first discuss the thoracic outlet. The outlet has a superior and an inferior border. The superior border is made up of the clavicle, and the inferior border is the first rib. Notice the clavicle labeled right here, and the first rib is labeled right here. And you can see several vessels that travel through this outlet right here. Now, these structures that travel through the outlet include the subclavian artery, the subclavian vein, and the brachial plexus. This image is described in great detail in cardiovascular anatomy. I just want to point out that the subclavian artery right here will take blood from the aortic arch right here, and it will deliver it to the arm. And this image describes the important venous structures that was also discussed in cardiovascular anatomy. Notice the subclavian vein right here, labeled on both sides. This collects blood from the upper arm and delivers it to the heart. You can see the subclavian artery right here, the subclavian vein right here, and the brachial plexus traveling through here, labeled here. If these structures get compressed, the patient can experience symptoms. And when these symptoms occur, this is known as thoracic outlet syndrome. And when there is compression of certain components, what symptoms does this lead to? Well, it depends on what structure is involved. If the brachial plexus is compressed, the patient can experience weakness, pain, and tingling of their arm. Nearly any part of the brachial plexus can be involved in the thoracic outlet syndrome, so don't get wrapped up thinking about specific branches of the plexus. Just know that the patient can experience weakness, pain, and tingling. But the symptoms that the patient has, in terms of location, represents that of a lower trunk lesion, and that was discussed in Section 2 of this chapter. If the subclavian artery is compressed, this can lead to exertional arm pain, also called claudication. So if the patient is moving their arm around or exerting themselves in some way, this can cause pain. But at rest, they wouldn't have the pain. Finally, if the subclavian vein is compressed, this will lead to venous congestion. And naturally, this will lead to swelling, specifically swelling of the upper arm. Now let's talk about the scalene triangle. To see this region, we need to look above the clavicle. The scalene triangle is bordered by the anterior scalene and the middle scalene muscles. And of course, the inferior border of the triangle is the clavicle, as we pointed out on the previous image. This region can also cause thoracic outlet syndrome, and that's because the brachial plexus runs through it. And this thoracic outlet syndrome can occur from overuse injury or inflammation of those scalene muscles, either of which can compress the brachial plexus. Now, the scalene triangle can cause thoracic outlet syndrome for another reason, and that occurs if there's presence of an anomalous cervical rib. And this makes sense. There's an extra bone in the scalene triangle region, and so if it's there, then it's more likely to cause disruption and inflammation, which can, of course, compress the brachial plexus. Another clinical tie-in is, since the brachial plexus is in this triangle, you can target the scalene triangle in order to perform a brachial plexus nerve block. These are the scalene muscles. We have the anterior scalene, the middle scalene, and the posterior scalene. It's between the anterior and middle scalenes that the brachial plexus travels. Now let's imagine a cervical rib in this region. A cervical rib would be abnormal, but if present, they can cause numbness and tingling from thoracic outlet syndrome. Now let's do a question to apply what you've learned. An anesthesiologist is attempting to anesthetize the brachial plexus in the thoracic outlet. With relation to the posterior scalene and the sternocleidomastoid muscles, where should the injection be placed to approximate the brachial plexus? Well, recall that the brachial plexus runs between the anterior scalene and the middle scalene. And if we use this image, we can show the scalenes right here, and recall that the scalene triangle is made up of the clavicle, as well as the anterior and middle scalenes. And it's through here that the brachial plexus would travel. And our question asks, with relation to the posterior scalene and the sternocleidomastoid muscles, where is the brachial plexus? Well, as you can see, it would be posterior to the sternocleidomastoid, which is labeled here. And since we know that the brachial plexus runs between the anterior and the middle scalene muscles, then we know that it must run anterior to the posterior scalene muscles, which answers our question. The injection should be placed anterior to the posterior scalene and posterior to the sternocleidomastoid muscle. Now let's talk about the rotator cuff. The cuff is composed of 4 muscles. These 4 muscles act to stabilize the glenohumeral joint, or the shoulder joint. And your job is to understand the function of each muscle and to recognize associated pathology. To help you do this, we've provided this table, and this table summarizes the information you need to know about each of the 4 muscles. We have the supraspinatus muscle and the infraspinatus, and both of these are innervated by the suprascapular nerve. The supraspinatus allows abduction of the arm to the first 15 degrees. So abduction from 0 to 15 degrees. In section 1 of this chapter, we discussed the axillary nerve, and in that lecture, we discussed how the deltoid muscle performs abduction above 15 degrees. So the supraspinatus does the first 15, and the deltoid does the rest. And what does the infraspinatus muscle do? It allows external rotation. In the first section, which I just referred to, we introduced the memory hook, infection, INF for infraspinatus, and ection for external rotation, infection. The left image highlights the supraspinatus, and the right image highlights the infraspinatus. More details regarding these muscles can be found in the section covering the suprascapular nerve, or section 1. But I want you to be familiar with where these muscles are in relation to the glenohumeral joint. So here is an image showing the anterior shoulder, which can be found in section 4 of your musculoskeletal anatomy text. From this anterior perspective, we see 2 of the 4 rotator cuff muscles. We see the subscapularis right here, this big one, and we can also see the supraspinatus right here. Now this image shows the musculature around the scapula from a posterior perspective. From this view, we can see 3 of the 4 rotator cuff muscles, the supraspinatus and the infraspinatus. We can also see the teres minor muscle. And as I mentioned before, this shoulder joint is also called the glenohumeral joint. The glenohumeral joint can be seen here. We have the glenoid fossa, and that resides on the scapula, and we have the head of the humerus right here, hence the term glenohumeral joint. The right image shows an additional perspective. We can see the glenoid fossa right here. Then you can see the clavicle and components of the scapula, the acromion and the coracoid process. You can also see the tendons of several of the muscles involved, the supraspinatus, infraspinatus, and the subscapularis. Now, although the biceps tendon is in the glenohumeral joint, it is not a rotator cuff muscle. So going back to just the supraspinatus and infraspinatus muscles, we've discussed the function of each of them and the innervation of them. The suprascapular nerve does this. And in the first section, when we discussed the supraspinatus and infraspinatus in more detail, we discussed how injury can lead to weak abduction for the supraspinatus. After all, it does the first 15 degrees. And the infraspinatus, responsible for external rotation, means that injury would lead to weak external rotation. What I would like to point out now is that the tendon can be impinged, leading to pain with abduction. When you look at this image, it makes sense that the supraspinatus would be responsible for abduction. If it contracts, the humerus, right here, would be pulled up like that. But what I really want to draw your attention to is this tendon. Notice how it rests just below the acromion right here. It's labeled on this left image. Every time someone abducts their arm, the supraspinatus tendon draws closer to the acromion. That means the direct contact and repetitive use of this muscle can actually lead to supraspinatus impingement. So every time the patient lifts their arm or abducts their arm, they can have pain. And this pain can be significant. Now that we've reviewed the supraspinatus and infraspinatus muscle, let's do a question to apply what you've learned. A 19-year-old female presents to the physician with upper arm pain following a sports injury. An MRI confirms the tear and a radiologist indicates the location with an arrow. The patient will most likely have difficulty with what movement? As indicated in the question stem, we can see the arrow right here. And you can see the head of the humerus right here. And we can see the acromion right here. And we know that the supraspinatus muscle travels between these two in order to reach the lateral side of the humeral head. And you can see it traveling through these structures. So if there's a tear of the supraspinatus muscle, the patient will most likely have difficulty with what movement? Well, what does the supraspinatus muscle do? It abducts the shoulder. Therefore, the patient would have difficulty with abduction, specifically from 0 to 15 degrees. Okay, now let's return to this table. We're going to discuss the teres minor muscle and the subscapularis muscle. Now the teres minor muscle is responsible for external rotation. Notice here that I've also written adduction. I don't want you to get wrapped up in this idea though, because it's such a minor contributor to adduction, and with teres minor dysfunction, you really should be thinking about external rotation being dysfunctional. And going back to this image, we see the teres minor muscle right here and the infraspinatus muscle right here. Do you remember what the infraspinatus muscle does? It causes external rotation. After all, we have the memory hook, infection. And if you can remember that the infraspinatus muscle is responsible for external rotation, then you can see that the teres minor muscle, which looks very similar in position, would also do external rotation. It has a very similar origin and attachment, here and here. So, just like the infraspinatus muscle, if there's nerve injury, it can lead to weak external rotation. Now you may notice that I've written here under the innervation column, axillary nerve, but it's small. And it's small for a reason. It means you don't need to waste a lot of time trying to tie axillary nerve and the teres minor muscle together. And that's because it's just not a very important point. When you think of axillary nerve, remember that you should be thinking of the deltoid muscle. And finally, the subscapularis muscle is responsible for internal rotation, which we stated before. And just like with the teres minor muscle, it's a minor contributor to adduction, but don't get wound up on this idea. Also, the innervation is not super high yield, so I wouldn't waste precious headspace with this information. But what is important is to know how they would present if the nerve was injured. They would present with weak internal rotation. Going back to this image, which shows the subscapularis muscle, you can see that it attaches here to this anterior portion of the humerus. So if the subscapularis muscle contracts, you can imagine that the humerus would rotate internally like this, because it's getting pulled in that direction. So if there's damage to the subscapularis, internal rotation would be weak. If you can remember the location of the subscapularis on the anterior side of the scapula, you'll also remember that it's responsible for internal rotation. But failing that, we have this memory hook here for you. Sub-I. Now, sub-I refers to an important clinical clerkship before your intern year, so it may be something that you've actually heard already. In any case, you will become very familiar with this line, sub-I, and we like to use this term to help you remember that the subscapularis is responsible for internal rotation. Sub-I, subscapularis, internal rotation. Now let's do a question to apply what you've learned so far. A 15-year-old boy says his left arm feels weaker than normal after a biking accident. On exam, the boy is instructed to keep his upper limbs in the position shown below. The physician places her own hand against the boy's right palm and instructs the boy to push against her hand. He does this without difficulty. However, when the same action is performed with the boy's left arm, the boy cannot resist the physician's hand. This patient is most likely experiencing weakness in what muscle? Hopefully in the question stem you notice that the patient is unable to perform internal rotation with his arm. His palms were facing medially, and he had to press against the physician's hand. This is internal rotation. What muscle performs internal rotation? Well, remember the term sub-I. Internal rotation is done by the subscapularis muscle. Sub for subscapularis. So this patient is most likely experiencing weakness in what muscle? The subscapularis muscle. Now we just need to discuss some last important shoulder region muscles: the latissimus dorsi, the trapezius, the sternocleidomastoid muscle, and the pectoralis major. This table shows you the information that you need to be familiar with regarding these four muscles. Starting with the latissimus dorsi, this muscle causes extension and adduction of the shoulder joint, and it's innervated by the thoracodorsal nerve. This image shows the latissimus dorsi, which is labeled here, and this muscle aids in adduction of the arm, which means it would pull it inward. The fact that it causes adduction is reasonable if you think of its location. It goes from the back, right here, and attaches to the humerus. If it contracts, it would be pulled down, as we indicated with the arrow, or rather, adducted. And as we mentioned on the previous slide, it's innervated by the thoracodorsal nerve. To remember that it's the thoracodorsal nerve that innervates the latissimus dorsi, I just realized that the latissimus dorsi is on the thorax, specifically the dorsal part. And if the latissimus dorsi is on the dorsal part of the thorax, it must be innervated by the thoracodorsal nerve. Now let's talk about the trapezius. This allows for scapula movement, and it's innervated by the spinal accessory nerve, which is cranial nerve 11. We can see the trapezius muscle labeled right here. If it contracts, the scapula will move upward. Again, it's innervated by cranial nerve 11, also known as the spinal accessory nerve. Now let's move on to the sternocleidomastoid muscle. This allows the neck to rotate from side to side. However, if both the left and right sternocleidomastoid muscles contract at the same time, the neck will flex. So in other words, bilateral contraction will lead to neck flexion instead of rotation. And just like the trapezius muscle, the sternocleidomastoid muscle is innervated by cranial nerve 11, the spinal accessory nerve. Here's an image of the sternocleidomastoid muscle. I'll just write SCM, and it helps with turning the head. This image also shows the sternocleidomastoid, which again is innervated by cranial nerve 11. And since we're on this image, let's dive into our last muscle, the pectoralis major muscle. Now the anatomy here is kind of interesting, because you may have noticed that both the pectoralis major muscle and the sternocleidomastoid muscle attach to the clavicle. So let's suppose there is a fracture of the clavicle. If the pectoralis major muscle contracts, it would pull part of the clavicle downward, while the SCM, the sternocleidomastoid muscle, would pull the bone fragment up. And based on their attachments, which you can clearly see, the pectoralis major muscle would pull the lateral portion of the clavicle down, while the SCM would pull the medial portion of the bone up. So returning to the table, we just discussed the sternocleidomastoid, which causes neck rotation, but with bilateral contraction, there is neck flexion. And just like the trapezius muscle, it's innervated by the spinal accessory nerve, cranial nerve 11. And the pectoralis major muscle causes shoulder flexion, and it's innervated by the pectoral nerves. Going back to this image, you can imagine that if the pectoralis major muscle contracts, it would actually lift the arm, so there would be shoulder flexion. This was a very simplistic review of these muscles, and this simplicity is very important. Don't go crazy on these. Just know the facts that we pointed out in this lecture. If you know those, you'll rock your boards. Let's do one last question to tie everything together. A 24-year-old male regularly performs the exercise shown below. The right image demonstrates muscular contraction. By performing this exercise, the patient is hoping to strengthen a muscle that attaches to the iliac crest, as well as the humerus and spinous processes. What nerve innervates this muscle? Hopefully you recognize that the muscle described is the latissimus dorsi. In fact, this workout is often called the lat pull-down. A clue that the latissimus dorsi muscle is what we're dealing with is when the question stem stated that it attaches to the iliac crest, the humerus, and several spinous processes. And you can see that clearly with the latissimus dorsi labeled here. You don't need to remember all of these attachments. If you know the location of the latissimus dorsi, you can gather that it attaches to the spinous processes, as well as the iliac crest, and of course, the humerus. But the question asks, what nerve innervates this muscle? Well, remember that it's attached to the thorax, specifically the dorsal part of the thorax. Therefore, this is the thoracodorsal nerve. And that answers the question, and it concludes this section.